truly an honor to be able to join this group and this panel. I appreciate everyone being here and the invitation from Dr. Rimmer. And I will start off by saying that Dante, you are a hard act to follow. I will say that we have a few similarities. The first is my birthday is in May as well, so we're stubborn Taurus. And I too have a superpower of a positive parking karma. Thank you for the reminder about the headshots, because I have no financial disclosures, but I do have a personal one. My headshot is 15 years old, the one in your bio. So, but since I kind of still feel that way in my heart, I felt like I was still being honest in that. So, thank you for letting me share my work around stroke and caregiving. So, the objectives of the talk, I'd like to go over the importance of involving care partners into the rehab process, talk about my intervention that we developed with my team called CareSight, and the principles around autonomy supportive, creating an autonomy supportive environment and family-centered care, and how we collaborated that. We worked with stroke survivors and family members as a collaborative project to develop the intervention. And then finally about the humanities and how the humanities can support what we do in rehab and introduce you to the Journal of Humanities and Rehabilitation. So Sir William Osler was a physician and a philosopher in the early 1920s and 30s. And his quote, "We miss more by not seeing than by not knowing." We miss more by not seeing than by not knowing. And that resonates with me because I think so oftentimes in rehab, as I'm a physical therapist and as rehab clinicians, we're driven by, and importantly, about the principles of evidence-based practice, right? And so making sure the research supports the interventions we choose to help support people's recovery after stroke and navigating their disability. And I think one of the challenges when we do this is that it is easy to lose sight of the person in front of us. What are we not seeing? Are we not recognizing the role of their own identity and their lived experience of disability? And so when I think about this human dimension of research, I ask the researchers in the room, who is the family behind their data, right? We get pretty excited about seeing these really innovative ideas in our research interventions, but are we thinking about the often overlooked, impact on what those interventions look like on the families and the support systems of those we're trying to serve? So there's a sort of a saying in research. They say research is me search, right? And so certainly with me, my family had a big impact on the work and my passion around caregiving and stroke, and the real desire to identify ways we can better integrate the family into the rehab process. And so these are images of my father as he was going through rehab after his stroke, learning to walk with a platform walker with physical therapy, working with his occupational therapist. And certainly in my role as a caregiver, that experience shaped so much of how I formulated the intervention of CareSight. And so no one asks how I'm doing. Right? No one asks how I'm doing. That is a quote that I hear time and time again as each family member comes into my office, in my lab, and I'm talking to them about their experience, and that we do really good job in healthcare about patient-centered care, but I think that we tend to overlook about what's been the impact on the family. And so simply just asking families how you're doing is important. So this image really is just actually from my CareSight intervention of a care partner talking about some of the challenges in her role. So the impact of caregiving. Family care partners are an important prognostic indicator for stroke recovery. But approximately 80% of stroke survivors are discharged home, but they rely frequently on family members who feel unprepared for the role, and that can negatively impact a care partner's quality of life. And so these unmet care partner needs and the feeling of inadequate training have been cited by nearly 75% of all care partners of stroke survivors within this first few months after stroke, and that highlights a real important need for effective family education. And then shrinking healthcare resources are creating this additional burden on the family unit and shifting more care for stroke survivors to the home environment. So I think finding ways that we can support and help care partners during rehabilitation without adding to their care partner burden is a public health priority. So stroke survivors recognize in this qualitative study that was done recently, the stroke survivors felt that the support from their family members did help them a lot in persevering in their upper extremity activities. But the care partners were really concerned about this concept of nagging, and they didn't really know how hard to push their loved ones, right? And importantly, that sense of feeling like they're nagging their loved one was a source of family conflict around rehab-based activities. And so what we know from the research, especially in some of the work by Tammy Lynn Backus and nursing research, is that caregiving interventions that are focused on skill building, right, can be more helpful for care partners than just psychosocial support. So understanding more about the stroke, how to support their loved ones with mood and behavior changes, and recognizing what their own needs are as caregivers can reduce depression and improve quality of life. And so the intervention that we developed in my lab is called Care Partner and Collaborative Integrative Therapy. So I purposely and intentionally use the word care partner to underscore that the individual supporting the person with stroke is a partner in their care, not just a giver, but a partner in the rehab process. So CareSite consists of both these web-based educational modules that the care partner reviews, as well as collaboratively working with the care partner stroke survivor to develop an intervention and their own progressive home program. So it's a theory-based intervention with the idea that focused on skill building and problem solving that will improve, hopefully, stroke survivor physical function, but also reduce negative outcomes in caregiving. So when we talk about family-centered care and how that interacts with CareSite, in my experience in working in inpatient rehab, so oftentimes family education is really 1 to 2 days, and it's focused on safety with mobility and ADLs, working on nursing and medical management, right? There might be a little bit of time to talk about home exercise programs, but they're often static home programs. So when people leave rehab, we don't expect them to be static, right? There's, how can we develop interventions that are also progressive and accommodate and work with stroke survivors as they move along in the care continuum. So when we develop, one of the key principles of CareSite is first, collaborative goal setting. So obviously starting with the stroke survivor goals, what do they want to accomplish with the intervention? But importantly, so you can go back, importantly, developing goals from the care partner. What does the care partner need and want, and in the context of how the stroke survivor's recovery? And so what I mean by that is, so in my study focusing on upper extremity recovery, the stroke survivor may say, I really want to use my arm better to eat and maybe help with some meal prep. But the care partner says, well, I'm up late a lot of nights because it's the only time, after my loved one's gone to bed, my husband's gone to bed, I'm up late doing all the financial stuff, and it's the one time alone I have. But he likes to get up early in the morning. And so, if he could just get up and make his own coffee, I could sleep in for another hour, right? And so the skills around fine motor coordination, around meal prep, and whether you're holding the coffee or pouring the coffee grinds, there's still sort of a similar approach, but for him to be able to make his coffee independently will help her with her own self-care and getting more rest, right? It's very simple little slight shift in how we look at functional goals, but it doesn't happen if we don't talk with the care partner about their needs and help them think about what their goals might be. And collaborative practice. So understanding concepts of neuroplasticity. How do we recover from stroke? If you understand, the importance of practice and working at your challenge point, which means sometimes you have to, you're pushing kind of at the edge and you're succeeding at sometimes with an activity, but that's what really drives neuroplasticity. If you sort of get a little bit of the theory behind it, I think it helps you be more adherent to some of the exercises in the HOPE program that you developed. And the importance of this problem solving together so they can navigate tasks, and using autonomy supportive language, which I'll talk about in just a minute. And then finally, creating space for the care partner to understand that their needs and their self-care are just as important. Because if they don't take care of themselves, they can't take care of their loved one, right? So maybe their goals are really just around respite for care. Maybe it's getting more sleep or getting more exercise, but giving them space to create some of their own goals is really important. So the intervention care side is 6 modules. So they're learning concepts of neuroplasticity and recovery from stroke, this collaborative problem solving. They learn about how to create an autonomy supportive environment for their loved one, creating their own self-care goals, and there's some reflection modules. And then at the end of each module, there are reflection questions that the care partner reviews to help them think about what they learned and apply it to their own lived experience, what's happening in their home with themselves, right? So if they're learning about trying to do practice at home or trying to use these autonomy supportive strategies, what does that look like with their loved one? And getting them to reflect on that. And then these feedback questions about their experience of it helps us to respond and make the intervention better. So when I come back to when I was talking about one of the biggest challenges of family members that I've heard is the struggle with feeling like you're nagging your loved one to do the exercises that are functional activities, right? So creating an autonomy supportive environment means that you try to foster understanding another person's viewpoint, you're fostering empathy, you're providing rationale, provide choice, and non-controlling language. So an example of that might be going back to perhaps the stroke survivors trying to use their weaker arm to eat their meal, and they're getting really frustrated and they want to give up and use their stronger arm. And so the care partner can say, oh, well, you're not going to get any better if you don't practice. And the therapist said you really had to try to finish your whole meal. You can shift that language to be slightly a subtle change to say, wow, you're doing a really great job finishing your meal and using your weaker hand to cut, to cut the meat. But I see it's frustrating and tiring. Would you like offering choice? Do you want to just go ahead and use your stronger hand to finish the meal, and then we can practice activities later? So there you sort of use this non-controlling language, you offer choice and rationale, and motivational support, right? Another key aspect of CareSight is that I wanted to develop it alongside care partners and stroke survivors. So the idea for the research itself came from my own clinical experience working with families in stroke rehab, as well as my own experience as a caregiver. And then the protocol development, that the modules are videos of stroke survivor and care partners in their own home. They created it. So I went to their homes, I kind of told them about the concept, the idea, and they rolled with it. And I filmed them practicing activities and practicing using autonomy supportive language, doing collaborative problem solving. So it really is about them. They created it. And then they help provide input in how we can translate it into findings. And so the initial testing of this intervention was what's called a K23. And so in the top slide, sorry, I think sorry. So the first testing was a randomized clinical trial that I compared. I had experience in what's called CIMT, constraint-induced movement therapy, and I paired that with CareSight and then compared it to a control group that just received constraint-induced movement therapy alone. But it was a home-based administration of that. And so both groups, the stroke survivors, had really strong improvements in their upper extremity, but only in the CareSight group did the care partners see improvements. And so the top, if you see the top chart, there's a Backus Caregiving Outcome Scale that looks at some quality of life after caregiving. With the higher scores, more improved caregiving. So you see that the care partners are in both groups were really struggling with quality of life, but the CareSight group made more significant improvements that lasted, and then their strain also, the higher scores or more strain of caregiving, and those reduced, and they continued to reduce even after 1 month later. But importantly, the care partners' reflection on their experience. They said, I think my role is very, very important, that what I've understood from CareSight is that my role as a care partner, taking care of the stroke survivor, and at the same time, the importance of taking care of myself. And watching stroke survivors tell their stories gives me a different perspective and also gives me hope that recovery is possible. We tested this applying some of the same principles to walking and gait in a smaller study that was just a one group repeated measures study with 16 stroke survivor and care partner dyads. And one of the striking outcomes for this, there were improvements in walking and gait, and walking speed and some other gait and mobility measures, but importantly, we also saw reductions in fall risk in the stroke survivor, and the care partner did improve in their quality of life. And so now we're doing a fully virtual clinical trial that is looking at the impact of CareSight on upper extremity quality and quality of life for the stroke survivor and quality of life for the care partner. So we're trying to evaluate the efficacy of the intervention at 2 months follow-up, and then the sustainability. If we see any differences, are the effects sustained? So Telerehab, I think, offers a really important opportunity to foster family-centered care because, first, it reduces, it improves accessibility and reduces burden of travel, and our CareSight modules are basically on demand, so care partners can review it on their own time, and it can adapt around work schedules. And finally, Telerehab visits that allow us to go into the patient's home and really craft our intervention based on the context in their own home environment and responding to their needs more effectively. So kind of getting to the last 2 slides around the importance of humanities and how humanities may tie into this work that I'm doing. So when I mentioned about autonomy support, the key part of creating an autonomy supportive environment is helping others understand your other lived experience, fostering empathy. And so in the last module, I have a poem from a stroke survivor called Ode to a Stroke. And it's by far the most popular part of the entire CareSight intervention. And care partners say, I really got a sense of what his experience and his journey was. And so this is just an excerpt, but one of the lines he says, but life goes on. I will survive. I am told to work. I am alive. But does anyone know how angry I feel, depressed, in pain, a long time to heal? And this line a little bit lower, he says, where do I go from here? How do I rebuild my whole? right? So for me, I think it's a reminder of understanding the person in a broader sense of the identity. But what's unique about a poem is that it allows us to, using metaphor and imagery, to go into his experience and bring ourselves into it. And how do we see ourselves within this poetry? And the long arc for him of going through such challenges after stroke, but then at the end coming out with a sense of hope. So it leaves us with my one of my final slides is around the work. If you want to read the whole poem or hear Mr. Taylor recite it himself and talk about his experience, is this Journal of Humanities and Rehabilitation. So this is the first journal that in rehab science that integrates humanities and what we do in rehab. And it's a platform that supports a transdisciplinary dialogue between those of us in rehab, humanities scholars, and most importantly, individuals from the disability community. And so alongside publishing research articles and editorials and perspectives, we also publish content from individuals with from the disability community, whether they're your reflection narratives, art, poetry, and so that by centering the voice of individuals with lived experience, this journal becomes a more inclusive model of academic publishing that informs clinical practice and public policy. So coming back to their first talk today, right, that people at the center of the policy decisions being made today, they need to hear from us, right? They need to hear our stories. And JHR Hope is one of our hopes with JHR is to be a platform for those stories. So I've got these cards on each table. There's a card, and I really want to encourage you to think about how you may contribute. Students, if you want to engage, one of the other pillars of our group, of the journal, is graduate student training in digital humanities and how you can work and think about contributing to the journal yourselves. So I want to go back to Dante's talk. One of the most powerful points you said was that we're better and smarter together. So I think that really captures. I was wondering, I know you have a copyright of your of your name, but perhaps we can do a copyright of, that can be part of our slogan, right? And I want to say, let's talk, right? Because I think that with you as well, we all need money, and we're called a Diamond Access Journal, so there are no fees for subscriptions or submissions, so that reduces paywalls, it improves accessibility, and so one of my visions is to raise funding support so that I can bring folks like Dante on as part of our editorial board and staff to help shape our vision for what this journal can be. So I'm gonna have 1 minute left, 1 minute. So instead of my last slides, I wanted to do a quote from a singer-songwriter, Carrie Newcomer. When we think about the importance of our stories, especially in our time today, she says, in the next months and years, we will be asked to stand courageously with the stories we hold dear. It is going to ask us to be bold, to speak our truth, to tell our stories and the stories of others in peril. It's going to get uncomfortable, and listening to the genuine will always ask us to press right up to our growing edge and then step across. We will be telling the stories that lift us up, that expand our thinking, that speak the truth. We will be singing our stories, painting our stories, writing our stories, telling our stories. And as always, the stories of courage and truth and revolutionary love will always give us the grounding we need, even when the way forward is unclear. Thank you.